Hi guys, welcome back. The topic we're gonna study next is vasculitis, and I'll try to solve some controversies here. One, if they ask you what is the most common subtype of vasculitis when it comes to adult population, then when I was a student at your age, I used to always read regarding giant cell arteritis. But in the current edition of Harrison, he has categorically mentioned idiopathic cutaneous vasculitis as the most common variety. At the same time, when it comes to children, you see, in children of Asian descent, it is Kawasaki disease that is more common. As you will notice, lot of platforms mentioning Kawasaki disease. That is because OP Ghai says so. But in most of the Western textbooks, when it comes to kids, he has first written Henoch-Schönlein purpura and then Kawasaki disease. Well, I have tried to give you resolution to the problem, because if he's talking about Asian descent, if he's talking about Indian descent, then Kawasaki should be given a priority. Otherwise, Henoch-Schönlein purpura. And for the first one, I've anyway given the reference to 20th edition of Harrison. So first one will definitely not be having any kind of any controversial issue. I will now be describing clinical features of giant cell arteritis, which will involve the superficial temporal artery, also called as auriculotemporal artery, and you can palpate it at your TM joint. This disease will mainly affect geriatric population. So the question will begin by describing an old man. This is a retired military person. He's maybe talking about this because he's trying to say that this person has been fit all his life. This retired military officer who even now goes for 5 to 10 kilometer running or maybe morning walk. He's telling you that I have been running low grade fever for past couple of weeks. I've shown various doctors, they've done some tests ranging from investigations for tuberculosis and other infections like brucellosis. Everything is turning out to be negative. He says, along with fever, I also have pain on the side of my head. So I asked him, sir, can you just put your hand where it hurts? So he put his hand like this on the side of the head. You're aware that in tension headache, a person will put his hand to the front or maybe to the occiput. Tension headache or mainly migraine related headaches are mainly fronto-occipital, but this particular person is pointing like this only to maybe one side, and he's saying that I'm having pain in one side of my head and it is non-pulsatile. You see, migraine pain is always pulsatile. This particular person is describing a non-pulsatile temporal headache. Well, why is it occurring is because I'm not aware of this at the moment, but I'm speculating that the superficial temporal artery supplies the skin of the scalp. This artery is undergoing vasculitis and is becoming relatively narrow, so the lumen is progressively reducing and therefore there is ischemic pain in the skin of the scalp. Please remember, the topic that we're studying is an extracranial cause of headache. Migraine, raised ICP, they're all intracranial causes, but giant cell arteritis happens to be an extracranial cause of headache. It is the ischemia due to the narrowing of the superficial temporal artery which is responsible for these manifestations. And well, how did I come to know that this is giant cell arteritis? Because simply headache and fever will not make the diagnosis. Because this person was talking about a very specific manifestation, which is the key word in the MCQ that you need to look out for. He's saying, sir, when I start eating food, I start getting pain in my jaw. Jaw claudication can be seen either with temporomandibular arthritis, or jaw claudication can be a feature with giant cell arteritis, because the blood supply of the TM joint is hampered, and that is the same artery, superficial temporal artery. This artery will supply the skin of the scalp. The artery will also supply the TM joint. The narrowing of the artery is decreasing the blood supply, and therefore this symptom will come. I mean, this is so characteristic in your face kind of a manifestation that you don't read it anywhere else. When I will physically examine this person, I could feel a cord-like structure at the temporomandibular joint or adjacent to the temporomandibular joint. Now, the way we doctors are trained, any structure that is felt superficially, we think it to be a nerve. But I was thinking to myself, this can't be a nerve related to leprosy, because posterior auricle nerve that is involved in leprosy would be behind the ear, and here the lesion is anterior to the tragus. Based on these findings, I have decided to do a workup of this guy, which will involve two things. One is getting a ESR done, and the ESR report was very shocking. You see, ESR normal is 0 to 20 millimeter fall in the first hour for females and 0 to 8 millimeter in males. And in this guy, the ESR is 100 millimeter. I mean, what are the medical disorders where you get a ESR of 100? Though there's a huge list, I want you to remember the important ones from exam perspective: subacute bacterial endocarditis, multiple myeloma, and giant cell arteritis. I'm being very selective from the table where gross elevations of ESR are given in Harrison. It is SABE, multiple myeloma, and giant cell arteritis, where the values will touch 100 in the first hour itself. I mean, when you put the sample, due to gravity, the RBCs will exhibit Rulex formation, will settle down. So there would be a very grossly elevated ESR. In tuberculosis, you would have seen ESR of 50, 60. Most of the autoimmune disorders have an elevated ESR, but especially for giant cell arteritis, it is gross elevations. You see, normally ESR is only a prognostic test. No, they always teach you ESR is always prognostic, never diagnostic. But in this condition, when you read the diagnostic criteria, ESR gross elevation is mentioned as one of the features suggestive of diagnosis. I will be now doing a biopsy of this patient, and it might have to be repeated at more than one places. In fact, in this condition, the biopsy can also be having a therapeutic effect because it will cut the nerve endings and the pain sensation will reduce. The burning pain sensation, he may not use the word burning and stabbing because you see, patients are not so descriptive like you and me. So actually it is a burning pain on the side of the head, but he's perceiving it as a headache. Most patients will not say burning pain. He'll just say, sir, I'm having headache one side of my head. So when I do a biopsy, it will have a therapeutic effect as well because it will cut the nerve endings which are conducting the pain. The biopsy of this patient will reveal a very classical finding, and that is why we call it giant cell arteritis, because giant cells will be demonstrated. You can read about this topic even from pathology, where you will find neutrophilic infiltration present in all the three layers of the blood vessel. I mean, right from intima right up to the outermost layer, you will be having a uniform inflammation or a pan-arteritis. So apart from the giant cells component, I definitely want you to remember that it would be all layer of blood vessels getting involved in this case. For the management of headache of this person, I don't need to give any sumatriptan. I just need to give steroids as is the norm. In rheumatological disorders, the primary drug that is useful for management happens to be steroids. The topic is relatively a very straightforward one. He'll mainly describe temporal headache. I mean, this information that I've highlighted before you in the black box, if is given in any question, the first differential in geriatric age group should be kept like this. Obviously, if it's a younger patient, the causes of headache will vary, as I'll enumerate before you subsequently as well. There is also possibility very rarely that in these patients a branch of the internal carotid artery, because you see, superficial temporal artery is a branch of external carotid. Sometimes in these patients, internal carotid artery branch of ophthalmic artery might get involved, and because of the vasculitis of the ophthalmic artery, this person might even develop monoocular blindness. Two things that will always bring this disease to your notice in a multiple choice question will either be the word jaw claudication with temporal headache, or because jaw claudication is so in your face and easy to pick up, he might mention temporal headache with monoocular blindness as well. I have highlighted in the routine neurology sections that overall the most common cause of headache, why it would be occurring, would be called as tension headache, but this is always a diagnosis of exclusion. You need to rule out other intra and extracranial causes. If he changes the question to that of what is the most common cause of secondary headache, now do remember this word, the word is secondary headache, then the answer would be infection. Something like a sinusitis or maybe a rhinitis can even contribute to a headache component. But whenever it's gonna be pulsatile headache, we are gonna think in terms of migraine. You see, I'm not talking about thunderclap headache. Thunderclap headache is mainly in subarachnoid hemorrhage, though it can occur rarely in stroke also. But thunderclap headache as a term, thunderclap basically means headache will develop very fast. Over 1 minute, it will achieve maximum levels, and the person will be sitting. I mean, he's sitting like you and me normal, and suddenly when thunderclap headache begins, within 1 minute, the person will be sitting holding his head between his hands and will say, I think my head will explode. So thunderclap word is used to develop the fast onset within minutes of the headache, causing extreme distress to the patient. Pulsatile headache was migraine. Then I've already highlighted if he says temporal headache. You see, it could be a long question describing multiple manifestations of a patient, but in every long question, there are some key points, and those key points are the ones which are basically to be focused upon. That would be GCA. If he talks about a question that begins by describing an occipital headache occurring in a patient, then first differential is still tension headache. If it is not tension, you need to keep in your mind possibility of hypertension and then even basilar migraine. I have handled these issues even in central nervous system component, but because we were talking about a geriatric age group patient coming with a headache, intracranial cause of headache in geriatric age group could be brain tumor, but the extracranial cause that we've just studied is one of the leading causes of vasculitis. Remember, leading, not the commonest one, giant cell arteritis. Now I will compare these manifestations with that of HSP, Henox-Collin purpura, which has been asked as image-based question multiple times. One of the highlights of this condition is that it is a non-thrombocytopenic purpura. I want to highlight that once again because normally when you read purpura is a bleed. So first thought process is, why is the guy bleeding? Platelet count will be low. But in this condition, and that is the crux of most of MCQs, when you read the word non-thrombocytopenic purpura, this definitely gives a very distinct edge to the question as your final diagnosis. The antibody which is increased in this case is immunoglobulin A. Yeah, the same antibody that I've taught you elevated in Burgess disease in kidney, the same one is involved here, and this would activate the complement system, and we're going to talk about a complement mediated damage once again. Let us look at which are the body organs that can be affected by this immunoglobulin A mediated complement activation. One would be the blood vessels of the skin. They would be damaged, so they will easily rupture. Now, I want to highlight, imagine a child is sleeping. So when a person is sleeping, then due to gravity, the pressure will be mainly on the vessels on the back. So lots of time when this child will wake up, he will be having extensor purpura. Extensor purpura would mean that these bleeds would be present in the skin, on the buttocks, on the back of the thighs, on the calves of the patient, or on the back of the patient. It is on the back side where the manifestations would be seen. So this is one of the keywords that help you identify the question. In fact, even when an image-based question on Henox-Collin purpura has come, majority of students have been able to make the diagnosis in the first 10 seconds itself just by looking at the image, because the purpura was very characteristic only on the back of the patient. A mother might say my child is having measles or chickenpox, because for them a red rash could be, a viral exanthema, but then measles rash will begin from behind the ears, so it will be relatively smaller maculopapular. Chickenpox rash would be maybe on the extremities, that would be dewdrops appearance with maculopapulovesicular rash. So there is absolutely no reason why a dewdrop rash or chickenpox can ever be mixed up with extensor purpura. Plus obviously history also, because there might not be any fever present here. The next thing that's going to happen is vasculitis related to GI blood vessels, because the gastrointestinal tract blood vessels are getting involved. Therefore this child will exhibit lot of fussiness. He may not be eating food, so mother will initially say that it's a fussy child, I'm giving him food, he's not eating. Well, you see, children are not able to explain the abdominal pain symptoms as well as adults. So lots of times the child might be crying and he's not eating food, and he might be pressing on his tummy. Now mother is asking, are you having tummy ache? So he might shake his head like this, because child doesn't know, this is tummy ache. That's first time for him that in his life that his tummy is hurting at 4 years of age. So abdominal pain, and then subsequently fussy eating or no oral intake along with hematochezia. That's gonna be an important movement, because fresh blood in the stool is definitely gonna alarm the mother, and she's gonna describe this to you. That happens to be important diagnostic criteria. The third one is blood vessels related to the joint space or related to the synovium. So once the blood vessels which are related to the joint are also involved, therefore joint pain and arthralgia will also come in. So we need to demonstrate all these manifestations in a patient with specially the skin involvement and the GI involvement. That is when we think in terms of Henox-Collin purpura. In fact, I can just from important textbook mention these features, though I've already highlighted them before you, but just to show you that this is what is given in the textbook. One is the aspect of palpable purpura. Why is that important and it is extensor? Is because there could be a MCQ written in the textbook by the name of non-palpable purpura. Yes guys, can you tell me condition causing non-palpable purpura? You see, the thought process of ours is, because when I ask this question, most guys, they say, sir, you yourself told, no, purpura is a palpable bleed in the skin. If purpura is a palpable bleed in the skin, then how is it possible non-palpable? Well, my explanation is, if purpuras are very small, they may not be palpable. When would you get it? It's possible with ITP, idiopathic thrombocytopenic purpura. Another rated MCQ that I can squeeze in is pinch purpura. I mean, that's a very characteristic feature that you read in literature of amyloidosis. So I have tried to rather solve 3 MCQs for you. Let me repeat and reiterate them so that this becomes a permanent memory for you. If you ever read a question by the name of non-thrombocytopenic purpura, get the words right, guys. In exam, non-palpable, non-thrombocytopenic. I've seen people messing up. It is non-thrombocytopenic purpura for HSP, because why is the bleeding occurring in HSP? Is it thrombocytopenia? No, it is fragility of blood vessels. Why? Because of vasculitis. You see, the blood vessels have become fragile. So on the back of the child, buttocks of the child, back of the thigh of the child, and over the calves of the patient, that is where the purpuras will be seen. Along with this, the additional features of bowel angina can be present, and the diagnosis of this patient can be made with help of a biopsy. Well, where will you do a biopsy? Not in the bowel, not in the joint. You can do a skin biopsy. If I plan to do a workup of this particular kid, I cannot say that elevated IgA and low C3 levels are diagnostic of this condition, because elevated IgA and low C3 can be seen in so many other conditions. The best way to go in for diagnosis of this condition is to perform a biopsy that would be done of the skin, and that will show this classical manifestation. In fact, if you have read about this topic from Robbins, the pathologist would have used this very classical term, leukocytoclastic vasculitis. So I would like you to read this topic with the pathology lecture. I mean, you can just switch over to the pathology domain in case you have not listened to it fast, and then come back here so that you will be able to enhance your yield in this particular case. If I do a coagulogram in these patients, because the purpuras are being formed, so therefore there could be consumption. After all, there is going to be a vasculitis component. So because in these patients the clotting system is utilized, so therefore coagulogram might be deranged. It might be mildly deranged, but still in the MCQ, derangement of coagulogram can be given. And as is the norm in all cases of vasculitis, one of the primary agents that we will be using will be steroids. It's the bowel edema and the bowel pain which is pretty disabling in these patients. You might think that this child is having an abdominal emergency. Lots of these kids, because of this hematochezia and severe abdominal pain, are actually thought to be having a surgical problem, but it turned out that this diffuse abdominal pain is primarily because of this disease process. That is, combination of all these features would help you in knowing that we are discussing HSP. I again want to highlight extensor purpura is the keyword. If you get this word right, the rest of the question will be a piece of cake for you. I shall now be discussing a miscellaneous disease with you, that is scarlet fever, which you have to compare with features of Kawasaki disease. Well, Kawasaki disease can also present at 4 years of age, but there will be some subtle differences. Like in Kawasaki disease, which is discussed in the subsequent part of the app as well, the fever is usually present for 5 days or more with certain manifestations called as mucocutaneous lymph node syndrome. The mucocutaneous manifestations are very characteristic in the form of strawberry tongue, or they could be bulbar congestion, and they could also be lymphadenopathy. I want you to remember that in Kawasaki disease, you will always have a unilateral cervical lymphadenopathy, but in scarlet fever, it will mention bilateral cervical lymphadenopathy. Whenever you read the word strawberry tongue, you will obviously be biased to think in terms of both of these diseases. My objective is to sensitize you to the fact that should you think in terms of Kawasaki, which is an important cause of vasculitis in Indian children, or should you answer scarlet fever? That's the main objective of this discussion. And see what I'm writing next. The child is having a scarlet rash, which is present all over the body. That means simply a reddish rash with a sandpaper consistency. When you rub your hand or when you run your fingers over this rash, it will be very rough. Additional term that can help you in diagnosis from dermatology is Pastia's lines. Pastia's lines would be found at the flexular areas, like at the crease you will see these lines present where mild desquamation would be present. You see, in this particular case, I've not mentioned any bulbar congestion. I've not described any periungual peeling of the skin. I've not described any perianal peeling of the skin. You can listen to the discussion of Kawasaki disease in the subsequent part of the app, but I just want to sensitize you to the fact that for diagnosis of Kawasaki, you need to demonstrate MCL. MCL would stand for mucocutaneous lymph node syndrome, and the lymphadenopathy will be unilateral. Usually the fever will be for more than 5 days, and there will be some certain differences. The subtle differences that I've highlighted here is one, I've talked about sandpaper consistency of the rash, I've talked about Pastia's lines, I've talked about bilateral lymphadenopathy. They all tell you the fact that this is definitely not Kawasaki. If it is Kawasaki, the treatment is giving intravenous immunoglobulin with aspirin. Last time I've taught you intravenous immunoglobulin was for Guillain-Barré syndrome, but IVIG is used even in Kawasaki. The treatment for scarlet fever, because it's caused by a bacteria, that is Streptococcus pyogenes, so we can use simple ampicillin. It is sensitive to most of the antibiotics which are available, and gradually the incidence of scarlet fever in our country is reducing, primarily because of the easy availability of antibiotics. So mostly when the fever will come, mother will not wait for 4 days for all the rash and other manifestations to appear. She might go to some local RMP or registered medical practitioner, and she might take antibiotics, and therefore all these manifestations may not appear as well. The objective was mainly to explain to you that just by reading the word strawberry tongue, you are not to get biased towards diagnosis as either Kawasaki or as scarlet fever. Just read the question patiently, and specific terms that I've highlighted would help you identify the differences. Now, I will mention some more fruit inspired signs here. So we read about strawberry gallbladder, strawberry cervix, strawberry gingiva. Apart from this, in ENT, you read about strawberry nose. I hope you recall that, no? Rhinosporidosis. And then would be strawberry tongue is what we have just discussed. For the gallbladder, you will remember cholesterolosis. There is also an image of that in Bayesian love. Then for strawberry cervix, that would be Trichomonas vaginalis. For strawberry gingiva, that's a pure internal medicine question, guys. That would be Wegener's granulomatosis. Wegener's granulomatosis as a term has been removed from medical literature as of now. So now we don't use the word Wegener's granulomatosis, but we use the term granulomatosis with polyangiitis. I repeat that again. Wegener's word is replaced by GPA, granulomatosis with polyangiitis. For nose, I can make you remind from ENT itself, rhinosporidosis. I think this was the easiest one, which I find everybody answers very well. And for strawberry tongue, it could either be Kawasaki disease or it could be scarlet. The discussion of Kawasaki disease is given subsequently with Behçet's also. I have described it because here I have mainly tried to focus on not Kawasaki but scarlet fever, because when I try to talk only about Kawasaki, people mess up between these two questions. So I thought rather than discussing Kawasaki at this point, it is better to discuss the manifestations of scarlet fever. The next topic that I'll explain to you is called as Takayasu's arteritis, which is also called as pulseless disease. This is an important cause of renal artery stenosis in India because it causes ostial narrowing. The blood supply to kidneys compromised, so low GFR, high renin hypertension will ensue. This time I am showing this blood vessel involving the arch of the aorta. Well, starting from the arch of the aorta would be the brachiocephalic trunk, which has been drawn at the movement. Then would be the left common carotid artery, and then would be the left subclavian artery. When it comes to the right subclavian artery, it will be originating from the brachiocephalic trunk, and then the right common carotid has been shown. This is the left subclavian artery. This is the right subclavian artery. This I've written is BT, that is the brachiocephalic trunk. The problem in this disease would be ostial narrowing. So I have shown ostial narrowing on both the sides, but I've shown it to be relatively more present on the left side because this happens to be the most common blood vessel involved. Now let us understand the implications in the patient. The blood supply on this particular side will be substantially reduced. You can see less blood will be able to go into the left subclavian artery as compared to right subclavian artery. So one of the main presentations in multiple choice question for this particular topic will be unequal blood pressure between the left arm and the right arm. The highlight of this particular topic is unequal blood pressure. Ideally, when you record the blood pressure, you should record it in both the left and the right arm. But in this case, you will always have this finding of unequal BP between the left and the right arm, primarily because of ostial narrowing. The initial presentation of these patients will be arm claudication. Like whenever this person is using arms, like he has washed clothes of his and is putting the clothes on a string in the house or anywhere to dry, when you use your arms, that is when pain would be coming. This is a vascular claudication. Neurogenic claudication can be occurring due to disc prolapse. You see, if I'm having pain in my arms even at rest, when I'm not using them, it could be neurogenic. But if pain comes only when I use my arms, it would be an arterial cause. Initially, this arm claudication, the vascular cause may not be picked up, and this person, because of pain in the arms, might be going to orthopedician who might actually advise a MRI of the cervical spine. The MRI of the cervical spine in these patients might turn out to be normal or might show minimalistic changes of disc prolapse. You see, all of us have faulty sitting habits, so little bit of disc prolapse can occur in any one of us, but that does not mean that it will impinge on a nerve root and cause pain. This particular patient is not having any abnormality of the MRI, But still the orthopedician prescribed him gabapentin or pregabalin. The pain in his arm is still persisting. He came to the physician now. He showed me a prescription saying, see, I got a MRI cervical spine normal, but still I have pain in my arm, especially when I use them. On listening to this complaint, I checked the BP of this guy between the left arm as well as the right arm, and I noticed the fact that there was a disparity. Now, what is the disparity? It will be lower on the left. And I'm not saying higher on the right. I'm saying it might be lower even on the right side because costal narrowing is present on both sides. But the problem is that ostial narrowing on the left is substantially more. So therefore, sometimes you may not be able to even appreciate the radial artery of the patient. Pulseless disease is a term that is used so many times to describe this medical disorder, and the same theory that I was saying of ostial narrowing can now be applied to the renal artery of this person. So if there's a narrowing of the renal artery, the blood supply to the kidney is lesser. Low GFR will mean high renin hypertension, and that is where I said this statement. Leading cause of renal artery stenosis, especially in Indian scenario, is Takayasu's arteritis. I would like to remind you the fact that renal artery stenosis is a separate topic in the renal section. I've highlighted that if a person is after 60 years of age, he's a big time cigarette smoker, and you are having a renal artery stenosis, then your answer would be atherosclerosis of the renal artery. Please remember, in 60 years of age, atherosclerosis will cause an entire longitudinal narrowing. The whole length of the artery will be narrowed, but in Takayasu's arteritis, it will only be the ostia, the starting point of the artery. Remaining artery caliber is normal. It is only the ostia that will be relatively narrowed. If I talk about a young female from America, right, and she's having renal artery stenosis, then the disease that is usually not found in India but is seen abroad is fibromuscular dysplasia, FMD. But when you talk about India per se, then it is the topic that we are discussing at the moment, which might actually present with arm claudication. The topic of RAS has been discussed even separately in the kidney section. This is the details that I want you to remember, primarily for Takayasu, for which the investigation of choice would be a MRA. You see, for blood vessels, we obviously need to do angiography. The treatment of choice for Takayasu's is steroids. Some additional facts which also need to be understood and remembered from this discussion is that in a normal person like you and me, like I'm sitting on a chair at the moment when I'm teaching you, so the BP in the legs will be higher because of gravity. In a normal individual, BP in legs is more than the BP in the arms. Why? Because of the gravity component, and the difference between these two blood pressures in the leg versus arms is less than 20 millimeter of mercury. If you get a MCQ which is opposite, BP in the arms is more than that in the legs, reversal, then it is a feature of coarctation of aorta and has been taught in the cardiology section. I also want you to remember that if the BP in the legs, listen to this carefully, the BP in the legs is more than that in the arms, that is same as you and me. But the difference here is substantially more than 20 millimeter of mercury, then we call it Hill sign, that is found in aortic regurgitation. Do remember the subtle variations that I have mentioned. The details are BP differences in upper and lower limb for a normal person versus coarctation of aorta versus a patient of aortic regurgitation. What are the medical disorders that have been discussed till now where unequal BP between left and right arm has been specially substantiated or highlighted is what I say next. This is discussed in cardiology section. Again, a quick recap. Supravalvular aortic stenosis, that is written as SVAS. Here you have a CONDA, COANDA, CONDA effect, which contributes to this unequal BP. The jet of blood preferentially tends to go towards the right side. Then is the topic that we discussed, Takayasu. And the third cause I want you to remember is coarctation of aorta of the preductal variety. You see, we have post and preductal. Preductal usually has a pediatric presentation. Postductal later has a adult presentation. These are three important causes of unequal blood pressure between the left and the right side that should be remembered. The next topic I'll be explaining to you is vaginous granulomatosis, which is now written as granulomatosis with polyangiitis, that is GPA. And we'll compare that with polyarteritis nodosa. Well, vaginous granulomatosis can be having damage to the blood vessels of the upper respiratory tract, damage to the blood vessels of the lower respiratory tract as well as the kidneys, and therefore the manifestations that will come up will be that there would be epistaxis because of damage to these blood vessels. Now, instead of straight away commenting on the epistaxis component, he might talk about sinusitis. The blood supply is compromised, so there could be nasal ulcers that might be described on a recurrent basis, and then yes, the bleed can be described. Similarly, if the blood vessels of the lungs are damaged, you will read about recurrent episodes of hemoptysis, and he might even describe lung lesions in the form of a cavity. It could be multiple lung cavities developing in this case. Please remember the fact that you read about lung cavity with TB, but it's usually a single one. No, here multiple, because the blood supply of the lung tissue is gone, so there would be necrosis occurring, and then there could be secondary infection there also. But multiple lung cavities can be seen with GPA. And because the kidney blood vessels will be affected, there would be a hematuria. I want to remind you that hemoptysis and hematuria is what you read with Goodpasture syndrome. He has also asked about the antibody which is involved here, that is called as C-ANCA. He has asked that this antibody will act against which cytoplasmic antigen. So that would be answered by you as proteinase 3. That would be a combination of medicine and pathology in a single question. For treatment of this condition, we shall be using cyclophosphamide. Normally, whenever I describe a rheumatoid disorder to you, I always talk about steroids, but in this case, it would be cyclophosphamide, then is rituximab, I'm writing RTX, and yeah, steroids may also be used, but the first line drug or the drug of choice would be answered as what I've written, the one that causes hemorrhagic cystitis. Please remember, polyarteritis nodosa, pulmonary artery is not involved. Just remember from the PAN word, N basically stands for not involved. So hemoptysis will not be encountered ever in polyarteritis nodosa. The most common body organ involved in polyarteritis nodosa happens to be the kidney. Because the kidney blood vessels would be involved in this case, there can definitely be hematuria. But this hematuria is not occurring because of damage to the glomerulus. It is rather occurring due to damage to the blood vessels. So there are two things which are not seen in this condition. I'm just putting a crosshair to say glomerulonephritis is not seen with polyarteritis nodosa. Pulmonary artery involvement is not seen with respect to polyarteritis nodosa. So the crosshair means involvement is not present. The disease can cause necrotizing vasculitis that can affect the blood vessels supplying the tip of the fingers. So you will read about digital ulcers as well as digital gangrene. You don't read about gangrene in Wegener's granulomatosis, but PAN, it's peripheral blood vessels, the smaller blood vessels that are getting involved. You know that in PAN it is small to medium blood vessels that are involved, so that's why digital blood vessel involvement and manifestations are described. You will also read about hypertension in this condition because the branches of the renal artery, I'm not saying the main renal artery, it is the branches of renal artery that can be affected. So hypertension can be present. In fact, combination of hypertension and gangrene is something that you don't see anywhere else but in polyarteritis nodosa. So question can be a long one, but combination of these two features would help you in the diagnosis component. Then coronary artery vasculitis can occur, so MI will occur. There's a possibility that vasculitis of brain blood vessels will occur, so stroke features can occur in the patient. And if it is skin blood vessels getting involved, then you might be having a fishnet appearance of blood vessels, that is livido reticularis. Fishnet appearance on skin biopsy immunofluorescence is what you read with pemphigus vulgaris, but here I'm talking about simply not a biopsy. I'm just saying the physical appearance of the skin to naked eye. I'm not talking about any immunofluorescence study. To the naked eye, there would be a fishnet appearance of the blood vessels running in all directions, which we call as livido reticularis. The antibody that can be present in this case is P-ANCA. Though P-ANCA, where is it strongly positive? I'll mention on the subsequent slide. P-ANCA positivity can be present. I'm saying can be present. And he has also asked in the exam that this alphabet P, that's for the perinuclear antigen, is saying that this is directed against which antigen. So your answer would be myeloperoxidase. Two pathology domains here, proteinase 3 and then myeloperoxidase are the targets which are being affected in this particular case. Conditions where P-ANCA is going to be strongly positive. One of them is microscopic polyangiitis. The second is Churg-Strauss syndrome that you have read in pathology also. In fact, this Churg-Strauss syndrome name has also been discredited now. The current name is eosinophilic granulomatosis with polyangiitis. It is written as EGPA. GPA I've already told you, granulomatosis polyangiitis, just prefix the word E before it. And third time P-ANCA strong positivity has been discussed with respect to primary sclerosing cholangitis, which has been discussed in the liver section. The diseases which I want you to remember at the moment are, I would call them as microvascular vasculitis, because small blood vessels are involved here. The names are granulomatosis with polyangiitis, microscopic polyangiitis, and then eosinophilic granulomatosis with polyangiitis, EGPA, which is alternative name for Churg-Strauss. What I'll do here is try to link up the information of pathology with clinical domains. So we'll just make a table where we can compare these disorders. I'll talk about whether do you have a granuloma formation on a biopsy finding. Then is renal involvement. I'll talk about percentages. Then would be pulmonary manifestations. In pulmonary, I'll incorporate even upper respiratory tract manifestations also if valid. Lastly, I'll talk about association with asthma, and then I'll talk about any antibody which is valid or not. First of all, GPA word starts with alphabet G, so granuloma will be present in both GPA and EGPA, but granulomas will not be present in microscopic polyangiitis because there is no alphabet G. Then remember ENT manifestations, that is sinusitis, nasal ulcer can be seen with Wegener's granulomatosis, that is GPA. So ENT positive means that even upper respiratory tract manifestations would be present. In about 50% cases of MPA and 70% cases of EGPA, you may have these ENT manifestations, but predominantly they are in granulomatosis with polyangiitis. Renal involvement is maximum with microscopic polyangiitis. It is not possible for you to remember the figures, but you can just remember which is the main manifestation, that is renal involvement is mainly present in MPA. In contrast, ENT manifestation is mainly with GPA. When it comes to asthma, asthma is major feature of eosinophilic granulomatosis with polyangiitis, that is Churg-Strauss. Then is the antibodies that are C-ANCA, P-ANCA, and lastly once again P-ANCA coming up. You see, antibodies will not be a problem for you to crack. I mainly want you to remember the following domains. Renal manifestations are more common in microscopic polyangiitis. ENT manifestations are mainly present with respect to Wegener's granulomatosis, and asthma is mainly a presentation related to eosinophilic granulomatosis with polyangiitis. Now, because I've written the word eosinophilia here or associated with eosinophilic infiltration, so there is a possibility that to help you in the question, he might mention about this particular person developing eosinophilic gastroenteritis or eosinophilic esophagitis. Remember in the GI tract, I've talked about a feline esophagus with that corrugated appearance of the esophagus. That feline esophagus was discussed for eosinophilic esophagitis that may be associated with Churg-Strauss syndrome. This table that I have mentioned towards the end of this discussion, the technical term that I would like to put for this one, where capillaries are involved, venules are involved, arterioles are involved, is basically called as microvascular vasculitis. I mean, looks a very surprising term, but this is what is given in the textbook, microvascular vasculitis. Earlier I've talked about Takayasu, which is going to involve very large blood vessels, and now I'm going to talk about the very small blood vessels of the body getting involved. So it's a little overbearing to remember all this information, but I have tried to summarize majority of aspects of pathology and medicine in a single lecture so that you can listen to them and try to remember them. Hi guys, the next topic on the agenda is Behçet's disease. This is also called as Silk Route disease. So one of the hints that will always help you identify this question will be the ethnicity of the patient. You see, he will describe mostly an Arab patient coming from countries like Egypt or Turkey or Iran, Iraq, or let me say central part of Asia like China or Mongolia. So one ethnicity will help you. Even if the ethnicity part is not given, HLA-B5 positivity is definitely a welcome point given by the examiner. And then would be the clinical manifestations. Though one of the characteristic clinical manifestation of this person would be recurrent oral aphthous ulcers. Now I have described this recurrent aphthous ulcers even in a case of SLE as well. In SLE, there's a possibility that the aphthous ulcers might be painless. But when it comes to Behçet's disease, these would be painful and they would be occurring in crops. What I imply by crops is at least more than 3 times per year, and the patient will be distressed by them because, you know, if you have a painful aphthous ulcer, then eating spicy food will definitely be troublesome. Sometimes even drinking water might be troublesome. Now, how do you know that this is not SLE? The feature that would be present would be involvement of the genitals. There would be recurrent vulval ulcers developing in these patients, and lots of time these recurrent vulval ulcers might be misdiagnosed as herpes because herpes can reoccur. So lots of time a doctor might be under impression because the patient, when she came, she just described that she's having recurrent vulval ulcers rather than describing even the oral ulcer component, and therefore possibility of misdiagnosis as a STD is very much there. When it comes to a male patient, then the chances of misdiagnosis are slightly lesser, because in males, when genitalia are involved, then you do not have an ulcer on the glans penis or on the shaft of the penis, as is the norm in routine studies. In this case, you can be having a scrotal ulcer or ulcers. So for male patient, I don't find too much of a problem, but for a female patient, misdiagnosis as herpes per se is a distinct possibility. The third thing that will help you in sealing the diagnosis would be the ocular manifestation of this disease. That would be pus in the anterior chamber of the eye, as you can see in the image attached also, that is hypopyon. So he will write either pus in the anterior chamber of the eye associated with inflammation, or he will write the word anterior uveitis. So a shortcut that can be used to identify this condition is called as oro-oculogenital syndrome. As I highlighted earlier, I would like to repeat this. 2 points which will always help you in favoring or making a diagnosis of this in the exam would be: one, the ethnicity of the patient, countries like for example China, Turkey, Mongolia, or just saying the word Arab patient. Medical tourism is booming in India, and definitely the number of patients is increasing on a yearly basis. Now for the workup of this patient, the test that we do is again very peculiar, and it is called as Petharji test. In some books or MCQs, it might be written as Petharji phenomenon, but I'm just going to use the word not phenomenon, but test, because we are doing a workup of this guy. At this junction, do not confuse this with patch test that is done for contact dermatitis. Like if they give you a scenario of a young female, she purchased some artificial jewelry like earrings and nose pin, etc. And then after putting on this artificial jewelry, she started having redness and itching and a weeping lesion on the earlobe, and she's scratching it a lot. That is contact dermatitis. This could be due to nickel present in the artificial jewelry. So patch test is type 4 hypersensitivity reaction, but it is useful to identify contact dermatitis, whereas Petharji phenomenon is again type 4 hypersensitivity reaction, but this is useful to identify the current topic, oro-oculogenital syndrome. Well, what is Petharji test? You would be using a standard 23 gauge hypodermic needle, and you would then be pricking the patient on his forearm. You're not injecting anything like in Mantoux test, Lepromine test. You inject a purified protein derivative into the forearm. You are just making a prick with a needle. In a routine individual, if you prick on the forearm, it will just cause a bit of bleeding because the cutting edge of the needle is sharp. And then after 2 days or 3 days, you will just notice a small mark of a clot there, or the mark of the needle, and the lesion will disappear in few days. In a normal person, hypodermic needle prick on the forearm resolves on its own over the next couple of days. But in these patients, by 48 to 72 hours, you will notice a formation of a substantially nasty looking sterile pustule. So the point is that if they get injured, if these patients get injured, then on the extremities of these patients, small papillonodular lesions may also be seen. Though those papillonodular lesions will require some kind of trauma to manifest, so they have not been included in the diagnostic features of the disease. I want you to remember, from the image-based perspective, if you get a combination of aphthous ulcer plus the genital lesions and then hypopyon, then these three things together with Arab patient, or country names if given grade, or he just says Arab patient HLA-B5 and then describes these manifestations, you are bang on spot to identify this disease. I also want to highlight that Behçet's disease is read by you in pathology not only as an example of small vessel disease, but it is also an example of large vessel vasculitis. It can affect both small as well as large vessel. So the usual query of most students is that, fine sir, it could be large vessel vasculitis also, like in Takayasu you said there is a large vessel vasculitis like the arch of aorta or the left subclavian artery getting involved. Here which artery is involved? So though this large vessel vasculitis in Behçet's disease per se, I want to highlight, Behçet's disease causing large vessel vasculitis is though a rare fact, but because it is rare, I want you to remember that the blood vessel that can be involved here is pulmonary artery, and the involvement can be so nasty that this pulmonary artery can even rupture, contributing to a life-threatening hemoptysis in these patients. This is an extremely rare manifestation, but because it is rare, that is I want to highlight the fact that not only do you get a oro-oculogenital manifestations, but even pulmonary artery involvement can be seen. In fact, in this disease, when I say the word small vessel vasculitis, then they could be involvement of the blood vessels of the brain also. So they could be CNS manifestations also. They could be even encephalopathy kind of presentation, that is neuro-Behçet's. We read about neurosyphilis, we read about neurosarcoidosis, but today I'm telling you that there could also be neuro-Behçet's disease, which could actually be misdiagnosed by you initially as maybe herpes encephalitis. I said herpes encephalitis because you see this lady was having recurrent genital lesions, so I thought it is maybe herpes, and then she's acquired a herpes encephalitis also. The word is neurobehcets, for which the presentation will be of encephalopathy and it will respond to IV prednisolone. It will respond to steroids because this is an autoimmune disorder. Coming to the treatment of this condition, I will be using topical steroids primarily for management of the oral lesions as well as the genital lesions of the person, but not for ocular, because you see, if you're using steroids in the eye to treat this, there could even be a perforation of the cornea that might go undetected. So if in a multiple choice question he specially mentions regarding the ocular manifestation of Behcets and he says what would be given for treatment, the answer would be given not as topical steroids, it would be azathioprine. This is usually neglected by most of people, so I just want to highlight the topical steroids are good for oral ulcers as well as the genital ulcers. The main message that I'm trying to highlight is ethnicity of the patient, and these three words oro-oculogenital, if you fit them together, it becomes Behcet's disease. You could rarely be having neuro-Behcets also, for which we might have to use even IV methylprednisolone. Initial presentation is of encephalopathy. There might be unconsciousness or there might be abnormal behavior exhibited by the patient. In some cases, there might even be cortical venous thrombosis, but then all of this begins to respond once you have put the patient on the right treatment. Now, just like I described before you a disease which is having this shortcut oro-oculogenital, I next want to describe a disease to you where we will be having again three words coming up together, that is mucocutaneous lymph node syndrome. I'll give a description also how to crack this, but at the moment I just want you to remember the terminology. Kawasaki disease is what we are discussing next, and it can be cracked by the usage of word mucocutaneous lymph node syndrome. If you ever read a question that begins by saying ECG findings of MI are present in a 4-year-old child, you see, MI is what occurs at maybe 40, maybe 50, maybe 60 years of age, or maybe even older. In India, obviously, heart disease can occur relatively earlier, but then ECG findings of MI in a 4-year-old child is definitely not normal. Let's now understand how did this actually evolve. So I'll be giving an explanation for why this happened in the child, and then you will be able to relate to this particular question on Kawasaki disease relatively better. In the initial consultation, when this 5-year-old child was brought to me, he was having fever for past 5 days, and the mother had taken this child when he was having fever for only 1 day or 2 days to the nearest pediatrician. He had maybe suggested testing for COVID, which turned out to be negative. The family was tested for COVID. The mother is not having any fever. Father is not having any fever. Child is only having fever. Still, they tested everybody for COVID-19. It was negative. So the doctor thought that this could be related to any routine bacterial infection, and paracetamol was given. Along with that, maybe amoxiclav was given, because lots of time in children you have bacterial infections coming up. So the general physician or the pediatrics person had prescribed amoxicillin clavulanic acid together, and the child has been taking this medicine, but the fever is persisting. Now, when this mother brought this child over to me, like I'm practicing like a general physician, so I might be getting all kind of patients. No, it might be adults, it might be pediatric cases also. So I told the mother, by looking at the prescription of my colleague, that ma'am, I would suggest you to take your child to the same doctor, because he's already seen the case once, so he can at least evaluate it subsequently. This mother was a little adamant kind. She said, no, doctor, we have been to that doctor, we did not get good relief, so I want you to have a look at my child. Well, I'm not going to refuse the patient if she's so insistent. So I just put my hand across, like a child is sick. If I try to put him on the couch and examine him, he might start crying. I don't want to disturb a sick child. So the child is still in the lap of the mother, and I just put my hand across and I'm just palpating gently the lymph nodes in the neck of this child. And what I found was a unilateral cervical lymphadenopathy of this kid. When I found this cervical lymphadenopathy, I thought it is tonsillitis which is contributing to this manifestation. So I told the mother, let the baby be in your lap. I'm going to put in a tongue depressor and I'm going to evaluate the tonsils of your child. And she asked the child to open his mouth, because obviously if you ask the small child to open his mouth, he's going to just turn his head away, hide into the mother, and he's going to be very afraid of this alien environment that you've created. So the mother somehow convinced the child to open his mouth. I put in the tongue depressor. I thought the tonsils would be inflamed. They would be red. They might be exudate covering the tonsil. They might be pus points on the tonsil like follicular tonsillitis. None of that. Tonsils were normal size. They were not even red. They're not even inflamed. So I'm thinking at the back of my mind that, man, it's not even tonsillitis and still there is a lymphadenopathy. So what could be the reason? Now, when I was withdrawing the tongue depressor, that is in the, I was shining a light, obviously. So in that fading light, when I'm removing the tongue depressor fast, you see, in that light, I could notice that the tongue of this child was looking a little different from the normal appearance. So the next feature that I picked up accidentally during this oral examination, where tonsils were normal, was strawberry tongue. In this medical condition, initially the strawberry tongue may not be red, it might be white. So that question was asked, white strawberry tongue is a feature of, answer is Kawasaki disease. And then the same patient, the later part of the illness, this white might be replaced by red. So there might be exfoliation occurring and then the white would be replaced by red. So white strawberry and a red strawberry are sequential manifestations that can occur in Kawasaki disease. I next asked the mother, please remove the t-shirt of the child or the shirt of the child which he is wearing, and I noticed there is a rash. This rash was relatively red in color, so I'm using the word scarlet. Scarlet also means red. Now, traditionally, when you read about the rash component, you are thinking in terms of scarlet fever, because scarlet fever again would be having a strawberry tongue. But it is unlikely to have a unilateral cervical lymphadenopathy. If there is cervical lymphadenopathy in scarlet fever, it is usually bilateral or there's going to be no lymphadenopathy. I thought it could either be scarlet or is it Kawasaki. So let's examine the child further. I noticed that this child was having this peeling of the skin. This peeling of the skin can be present at the tips of the fingers, periungual, but actually starts from around the genitals. So now I'm going to ask the mother to remove the shorts of the child, the undergarments of the child, and that is when I might notice perianal peeling of the skin, and subsequently the mother might himself say, sir, see the fingertip skin is peeling off, or in the palms the skin is peeling off. The term used would be most of the time desquamation. Desquamation definitely helps you to identify that this could be Kawasaki presentation. I asked the mother, okay, put the clothes back on the child. I've did a physical examination. I've noticed he's having a rash, he's having a peeling of the skin. When she has put back the clothes on the child, I just had one last look at the child and his eyes were bloodshot red. I asked the mother, ma'am, are you sure? I mean, the eyes look so red. She says, yeah, doctor, it's been so for last 5 days. Bulbar congestion. But it is non-purulent. Like I asked the mother, is there any discharge in the morning? Is there, because if it's purulent, if it's bacterial conjunctivitis, there would be purulent discharge. She says, no, there's no pus. So what I am highlighting before you are certain points which are mentioned as American Heart Association criteria for identifying Behçet's disease. How to remember so many manifestations? I want you to focus on the words that I say. One is the word muco that I highlighted in color black. Muco would mean that this child could be having manifestations like strawberry tongue, or there could be a bulbar congestion. Then I'll focus on the word cutaneous. Cutaneous manifestation would be like a rash or a desquamation that I was highlighting. In fact, I would like to highlight this word desquamation that would be written in lot of questions at the specific sites that I mentioned. And lastly would be lymph node syndrome. So I highlighted there would be a unilateral cervical lymphadenopathy. You see, in the exam, you need to demonstrate MCL, the muco, the cutaneous, and the lymph node manifestations. And if you demonstrate all of these together that I've highlighted, then it is a diagnosis of Kawasaki disease. Kawasaki, guys, initially is a clinical diagnosis based on presentation of fever with all the information that I put in the box. Please remember the fact it is no big deal that you can misdiagnose this particular condition as scarlet fever also. But the points against scarlet fever would be that one, scarlet fever may not have this bulbar congestion. Scarlet fever per se may not have this unilateral cervical lymphadenopathy. Either there would be no lymph nodes in early part of the disease or bilateral cervical lymphadenopathy. Then you read about terms like Pastia lines and the rash having a sandpaper consistency. So had I used these terminologies, which I've obviously not done in the box, then I could have thought in terms of scarlet fever. I want to highlight the fact that scarlet fever is always the first differential diagnosis in a developing country like ours, where you get a strawberry tongue. But along with strawberry tongue, you need to look for these words either in image base or, let me say, the theory component that he's highlighting them, Pastia lines and sandpaper consistency of rash. If he highlights along with strawberry tongue, then it is scarlet fever. Otherwise, if he highlights words like unilateral cervical lymphadenopathy, bulbar congestion, desquamation occurring at the tip of the finger, you should think in terms of Kawasaki. When I told this mother, ma'am, I think that your child is having a cardiac issue. You see, guys, this mother is gonna freak out. She's gonna say, "Sir, you're overdiagnosing my child. Come on, my child is only having fever, na? And you are telling me my child is having a heart disease." I want you to understand that Kawasaki disease basically has coronary artery vasculitis, and this coronary artery vasculitis is manifesting in the form of these manifestations. So initially, there is a high probability that you may not be able to identify the condition, or even if you did, there's a distinct possibility that mother might think that you are overreacting. Therefore, this mother, she said, "No, no, doc, I think that you are not good enough to handle my child. I'll go back to the same doctor or show some other child. You are telling me my child has a heart disease and he can have a heart attack in future." This mother has not followed my advice. Now, please don't note down, just listen to my words very carefully. I had a mother, a anxious one. She's doing doctor shopping. She's already shown one pediatrics guy. Now she's coming to a general physician. She's asking about, okay, what is the diagnosis of my child? I said, "Ma'am, there could be a cardiac issue." She thinks I'm overreacting. She left my consultation chamber, or whatever treatment that I gave, she did not even bother to give it to the child. Now it is day 14, or even later, subsequently she is continuing with doctor shopping, and subsequently this child started developing chest pain. Now a 4-year-old child cannot describe chest pain. Therefore, most of the time, the child will become unconscious, because you see, this coronary artery vasculitis has triggered a MI in the child, though it may not happen in all cases, but there's a distinct possibility that if Kawasaki remains undiagnosed and untreated, there could be myocardial infarction in a child, and that could trigger a syncope. Now, because this child was unconscious, he was brought to my hospital. Let me say I'm running a nursing home. So, I mean, it's nearby the residence of this lady. So she brought the child over to my clinic, and I recognized that that's the same lady with the same child who had come to me a couple of days back. And I told her also, "Ma'am, you had come to me earlier," and she acknowledged that fact. In any unconscious child, you are supposed to run a ECG, and when I ran a ECG, I was in disbelief that am I seeing a ECG of a child or ECG of an adult patient with ST elevation MI? You can see very characteristic ST elevation MI with a T wave inversion in the ECG of this child, and I was surprised. I first thought this is not this child's ECG. Well, then I had to obviously treat the ST elevation in this case. I have taught you that for ST elevation myocardial infarction, we need to do a primary percutaneous coronary intervention. But the device, children's coronary arteries are very small. As a result of it, we cannot do PCI in children, because the balloon that is required, the technology that is required, is not available usually in India and even most hospitals in America. So we will have to do thrombolysis of this child. Now, writing this is very easy. You would understand biggest side effect of thrombolysis is hemorrhage, brain hemorrhage. So if you're doing thrombolysis in this little child, if you tend to overdo, if you try to do, or if you give a higher dose of thrombolytic drug than what is required, the child could end up with brain hemorrhage. So first you need a doctor to be aware of this fact that child can also have a MI. Assuming the doctor has seen a case like this before, then you need a doctor who's skilled enough to do thrombolysis in this child. But even if you do thrombolysis and you open up the blocked thrombosed coronary artery, the vasculitis component is still untreated. For the treatment of the vasculitis component, you will have to start this patient on intravenous immunoglobulins, that is antibody against antibody that will handle the vasculitis component in this particular case. So this is an unfortunate scenario due to which the child can even die. I'm now putting a line over this information to say that all this could have been prevented. All of this could have actually been prevented had I been a little more patient with this lady. You see, when she came to me in my previous consultation, I told her, "Ma'am, your child is having a heart issue." And she said, "You are overreacting." And I took it on my ego. You see, we doctors have very fragile ego. You would have noticed that. If somebody says something to us, we suddenly get very offended. How dare you say this to me? Right? So same thing happened here. I took this on my ego here, and this lady said, "No, no, doctor, I don't think so that you're right in your diagnosis." I said, "Okay, go and show somewhere else." At that point of time, if I was a little more considerate and more empathic, then I would have advised her to at least allow me to run an echo on this child. I'm not asking for angiography, though I've shown you an image of an angiography for evaluation of Kawasaki disease, you actually don't need to do an angiography. Had I done an echocardiography in this little baby with little small heart and small coronary arteries, you can be seeing giant aneurysms, which could be as much as more than 1 centimeter in size. Guys, in this condition, actually the vasculitis damages the coronary artery to the level that they could be aneurysms. These aneurysms can obviously be visualized on uh, uh, a coronary angiography, but there is no need for even doing a coronary angiography. Most of the time, even echo, they can be visualized. So had I been a little more patient and done an echo of this child on the earlier presentation, that was around about the 5th or the 6th day, I would have told this mother that, ma'am, I would like to start your child on combination of aspirin plus immunoglobulins. Last time I taught you intravenous immunoglobulins was for Guillain-Barré syndrome. Last time I taught you aspirin, especially from pediatric perspective, was rheumatic fever. Today I'm teaching you aspirin plus IVIG combination. If they ask you to select one, your answer will mainly be intravenous immunoglobulins. Please remember echo that I've written here in red color is outside the green box. I wanted to highlight that the American Heart Association criteria that I have explained to you for this particular topic do not include echocardiography. Though the laboratory reports may even be given, thrombocytopenia or counts might be given, CBC of this person, or even positive CRP in this case, I want you to understand that no blood tests are included in the AHA criteria for diagnosis of Kawasaki disease. Echocardiography, angiography, none of them are included in the diagnostic criteria. We have to evaluate and rule out scarlet fever. We have to rule out tonsillitis in a child. That is when we think in terms of Kawasaki, which is a rare disorder. And yes, I mean, per se, I can say that this is the important cause of vasculitis in pediatric age group. Overall, in pediatric age group, it is Henoch-Collin purpura. Though I think you are very clear, and I know you are itching to actually send me a message across at the moment saying, sir, that in some forums it is written that Kawasaki is the commonest cause of vasculitis with reference of Opigai. I just want to highlight that if you look at Nelson still mentions the commonest cause of vasculitis in pediatric age group as Henoch-Collin purpura. The incidence of HSP is obviously relatively more as compared to that of Kawasaki disease. That's the reference that I have from Nelson, and I think that Nelson would be having more credibility over the Indian book Opigai. No disrespect to any book or any forum. I just want to highlight that this controversy has been there since I was a student. You know, even at my age, I used to be wondering in some books Kawasaki, some books Henoch-Collin purpura. So if this controversy has not been solved in so many years, it won't be, and you don't need to bother about it. And anyway, nowadays he's giving you case-based scenarios. So he's rather gonna give you a scenario like this and ask you to identify this child who's having myocardial infarction findings. To finish this, I also want you to understand that what I wrote here should obviously not happen. I mean, we should try to make a diagnosis in the first or the second consultation and not wait for the child to suffer from MI. I would like to finish this discussion by mentioning a very peculiar question that a student of mine shared. He said, sir, the question was ECG finding of myocardial infarction, the traditional ST elevation, T wave inversion, was asked for a newborn baby. You see, I've taught you ECG findings of MI in a child now. Now I'm asking you question saying ECG finding of MI in a newborn baby is due to, your answer is L kappa. Now listen to my words very carefully. L kappa would mean anomalous origin of left coronary artery. LCA would stand for left coronary artery. In a normal person, the coronary arteries would be originating from the root of the aorta, but in this particular case, the LCA is originating from the pulmonary artery. PA is pulmonary artery. So you can understand, no, that the left coronary artery will be having deoxygenated blood, and that deoxygenated blood will definitely contribute to myocardial ischemia, resulting in these findings. So do remember these two standard questions which could be given in a case scenario, but the bottom line is newborn baby having a MI and a child having a MI is not a normal thing. Obviously, I mean, you know, why I'm saying normal is because heart disease incidence is so common in our country that myocardial infarction is one of the leading causes of mortality, or coronary artery disease is one of the leading causes of mortality in our country. It's just COVID that came in between, but otherwise CAD was the number one case of mortality for per se for developing countries. I want you to remember two MCQs here. One is MCL, mucocutaneous lymph node syndrome. Be very judicious in deploying it. Do not misdiagnose Scarlet versus Kawasaki. You know, the reason being that certain features that are put in the green box are neglected by people. So they tend to answer it as Kawasaki even when these features are not given. I'm saying ulta. You see, people have so much of impression, or most doctors have this fancy to answer Kawasaki disease, that the moment they read strawberry tongue, they tend to mark as Kawasaki. I want you to be a little judicious and try to look for features that I've highlighted, like unilateral cervical lymphadenopathy, bulbar congestion, etc. So you are smart people, you will obviously be able to do it. It was my responsibility just to warn you that I have seen people actually overdiagnosing Kawasaki disease in the exam, whereas it was scarlet fever. Apart from this, I've also taught you about this medical tourism aspect, where this would be an Arab patient and would come to you with combination of oro-oculogenital manifestations. These are the details for these relatively simpler topics. Thank you so much for your patience and hearing me out.